Sometimes in medicine, the most critical procedures are actually the ones you hear about the least. Today, we're going to talk about one of them, the hysterotomy. We're going to break down exactly what it is, why it's really a last resort, and the serious risks involved, all based on established clinical protocols.
Okay, so let's dive right in. What is a hysterotomy? Well, it's a surgical operation where a doctor makes an incision, a cut, directly into the wall of the uterus to remove a fetus and placenta. That's what's medically known as the products of conception. And the key thing to remember here is the timing. This is done before the fetus is considered viable, which is generally before the 28th week of pregnancy.
So, we have this very specific definition, right? But what's really interesting, and something all the clinical sources agree on, is that this procedure is incredibly rare in modern medicine. You just don't see it performed very often.
And that just begs the question, doesn't it? If it's so uncommon, when on earth would you ever actually need to do one? What are those specific, really complex situations where this becomes the only option?
Well, that question takes us right into the very specific medical reasons, the clinical indications, for performing a hysterotomy. Let's take a look at when it's absolutely necessary.
So you've got to understand, this is not a first choice. This is a last resort, used only when other methods have either failed or are just too dangerous. We're talking about situations like a failed medical termination of pregnancy in the second trimester, or when things like fibroids are physically blocking the lower part of the uterus. It's also indicated for what's called placenta previa, where the placenta is completely covering the cervix, or if the uterus itself has structural issues. And in some really serious cases, it might be necessary if cervical cancer is discovered during pregnancy or for patients who've had many C-sections in the past.
Okay, so we've covered the why. Now let's get into the how. What actually happens during the surgery? Let's walk through the procedure, step by step. First things first, the prep work. It's pretty much what you'd imagine for any big abdominal surgery. The patient is put under either general or epidural anesthesia, and the surgeon opens the abdomen to get access to the uterus. All right, this breaks down the whole operation. Let's walk through it. First, the surgeon actually lifts the uterus out of the abdomen and packs the area around it with surgical pads. This is super important to prevent contamination. Second, a medication is given to help the uterus contract, and then a small 5-centimeter vertical cut is made right into the uterine wall. Third, the contents are removed and the inside of the uterus is cleaned out. Now, step 4 is absolutely crucial. The uterine wall is very carefully closed in 3 separate layers. This is to make sure the repair is as strong as it can possibly be. And finally, those protective packs are taken out, everything is cleaned up, and the abdominal wall is closed.
Of course, like any major operation, this isn't without its risks, and it's really helpful to think about these in 2 buckets: the immediate dangers you might face right after surgery, and then the more remote, long-term concerns that could pop up later on.
Let's break this down. On the immediate side, you have the kinds of risks you might expect, things like heavy bleeding from the uterus, infection, blockages in the intestine, and of course, the general hazards that come with anesthesia. But then you have the long-term risks, which can show up much later. We're talking about menstrual problems, a painful condition called scar endometriosis, and this is the big one, the danger that the scar on the uterus could actually rupture during a future pregnancy.
And to put one of those long-term risks into perspective, clinical data suggests there's about a 1% chance of developing what's called scar endometriosis. That's where tissue similar to the uterine lining starts to grow on the surgical scar itself. And believe me, that can cause some pretty significant problems down the road.
And all these potential complications, they really lead us to the biggest takeaway here, the long-term outlook. This is a really serious consideration for both the medical team and the patient when they're making this decision.
There's a line from the clinical protocol that just perfectly sums up the dilemma. It says, while concurrent sterilization eliminates the hazards, but those left exposed to future pregnancy become a growing concern. What that's basically saying is, if the patient is sterilized at the same time, these future risks go away. But if not, that scar on the uterus becomes a huge, ongoing risk for any pregnancies later in life.
So that's really the core issue here, isn't it? It leaves us with a really tough question to think about. How do doctors and patients possibly weigh the immediate, sometimes life-saving need for a procedure this rare against its really profound and lasting long-term consequences? It's a complex balancing act, and it's right at the heart of modern medicine.